Mtazamaji, tunaangazia mzigo wa saratani, na ni ugonjwa ambao umeweza kuangamiza wengi, wengine wakiathirika kwa njia moja au nyingine, labda kwa kutumia pesa nyingi katika kufanikisha matibabu. Na tunakujia mubashara kabisa kutoka ukumbi kuu wa Chandaria katika chuo kikuu cha Nairobi, ili tukizungumza na wale wataalam na vile vile hadhira ambayo wamekaa hapa ili kuweza kutupa hisia zao kuhusiana na masuala haya ya saratani. Na hapa mbele niko na wataalam and now I would like to know from Prof, we are talking about the less funds or a deficit when it comes to funds in treating cancer. As oncologists, how are you managing the growing numbers of patients, especially when it comes to treatment?
To be fair, we're not managing. The people who suffer are in the audience. And the question becomes, it is easy to say we should prevent, but we should not make mammography cheaper, pap smears cheaper, the vaccine cheaper, then even prevention does not work. So in many ways, the burden is then shifted from the government to the populace, and we are not managing well.
Thank you for that. And we've talked about misdiagnosis. We've talked about late diagnosis. What can we do as a country going forward?
You know, we are here at Nairobi University that has a medical school. We have a colleague here from Nairobi University. I heard all three patients talk about misdiagnosis by physicians who are trained in our country, who do mammographies, we do MRIs and CAT scans only to just push the patient another kick the can down the road. So we need to go back for the Nairobi universities, Kenya University for that matter, Kenyatta University, to say, what is the curriculum of physicians that we train in this country? Is the medicine that we give to our physicians the best knowledge we have? Or is it that they forget so quickly that when the patient comes to the door, they just reap their money, their funds, but the poor patient is left to carry the bag? So then I was asked my colleague, what is the curriculum that we have in this country for training physicians to provide adequate care?
AGCAN appears to be doing rather too well, without perhaps going into the details of what has been launched, a PET scan, and the activities that are playing out there. I think it paints a picture of just how the private sector is committed to this. Most of the times the government has been pointed fingers at, with the allegations that they are reactionary in nature, that when we find maybe a big person in society has lost their life to cancer, then we are all out there talking so much about this concern and how we're going to add oncological centers, how we're going to advance this and everything. What is this that we are perhaps not doing right, beyond the element of research, beyond the element of education, that perhaps maybe the private sector could be getting right compared to it? And why is it that we always then send our patients to India? What is this that they're doing that we are not doing?
You know, we need to understand, I come from AKU. It is a private, not-for-profit entity. 40% of our margins that we make are provided into, we talked about it here, into supporting those patients who do not have the means. Mm-hmm. I think the private sector is often very efficient. It is money-driven to be able to save money, but also save lives at the same time. So when we invest, for example, we heard the representative of the government says we put all these CAT scans and the PET scans and the SBRTs everywhere, but we do not have the resources. It's like having a machine gun, but no operator. Mm-hmm. The private sector asks the question a different way around. They say, before I invest in a big SBRT, what is the implementation science? What are the staff we need, the training we need, and who should be using SBRT to be very efficient? I think those are things that the government could learn from the private sector, in the sense that you are money conscious, efficient, and yes, you will make a profit. In the case of AKU, we turn the profit back to be able to help the resources of the patient that we serve. And I think everywhere you go in this world, the private sector has the efficiency model very right. But to be fair, the government has to deal with the entire populace. And the entire populace is often very impoverished, a very small percent of patients who can afford everything. So the government has a tough job to do. But I believe what we call public-private partnerships. We heard the government gave PET scans and CT scans to 4 centers. I've not seen the government give a CT scan to the El Khan University to say, here, we will donate this CT scan, teach us how to be efficient, and make it better for our patients. So I would like to see more public-private partnerships that we can then show the government how to be more efficient, and the government get from us how we can better serve the patient of this country.
We have CHPs, I believe, on the audience side. I would love for them to as well highlight just what then we need to do in terms of addressing these concerns of cancer and health at that primary level, vertical ground. So Sheila, before we come back to you, I think we have a question for Phoebe.
Phoebe, we've talked about the burden that is there, and we know when you work for KENCO, there are several organizations that you work with, and I earlier asked you about the same. So here we are talking about the burden that we have going forward, and also looking forward for eradicating mostly cervical cancer, as it is as per the World Health Organization. What are you doing as an organization to ensure we reach that goal?
And Phoebe, to add on to what it is that Onsari speaks of, I would love for you to as well highlight the concerns that come along with the mental torture and the drain that, of course, everybody gets to encounter, you know, caregivers as well as cancer patients, and not forgetting just how then we can loop in society as well to ensure that this then is addressed. We shun out stigma because it comes along with the same.
Thank you very much. Let me just start with what he has asked about the burden. Every day we are losing 10 women to cervical cancer, and yet this is the only cancer that can be prevented completely through vaccination and also through early diagnosis and screening. So what we are doing, we are really, we applaud the government for what they're doing with the HPV vaccination. And I think Ministry of Health is currently working on having a single dose vaccine for the 9 to 14-year-old. So as a CSOs, what we do is to amplify such. So currently we are doing a lot of awareness and training for the girls between 9 to 14 years, but we are calling for multi-sectoral engagements. We need the clerics, we need Ministry of Education, we need the patients, we need the parents, we need the teachers, we need the peer education club, so that everyone is on board to ensure that this burden goes down. One of the reasons why HIV project succeeded because what we call patient experts. So these patient experts were patients who are actually living with HIV, who are involved now to do the community health promotion and all that. So we are pushing that the same. As you hear, these are patients with lived experience. They know better on early screening. They know better on patient navigation. They know better on when to seek for treatment. We are urging that even as you recruit the community health promoters in the communities, let us consider the patients with lived experience, because they know it better, and they will do it from a peer-to-peer kind of approach. And just to overemphasize the importance of mental health. Most of the times in cancer care, we look at mental health towards the treatment, but we're emphasizing that mental health is so important right from diagnosis. As you go for that biopsy, there is fear, there's anxiety. We need to have it, the trained personnel, either the person doing the biopsy or healthcare workers or counselors who will take this patient through it. Because when a patient is mentally unstable, they will not adhere to medication. When they are mentally unstable, they will not have the quality of life that is concerned. So it is very important that we incorporate mental health, not only at the end or in the middle, but from the beginning. And it's important that all healthcare workers, and again, not overemphasize the ability of the lived experience patients who with mental health capacity and knowledge to navigate these patients right from biopsy to diagnosis and to treatment.
Yeah. Of course, we come to you, and we are curious, when we're talking about quality treatment, when you're talking about what the future is like, when we're talking about care in general, where does research come in? Because I'm assuming that in the process of research, we want to look at participatory approaches. We want to look at the situation locally, but we also want to look at, you know, say the bigger brothers, other countries. We have statistics here. We are not doing good, but at the same time, if you compare to other continents, we are at 50-something%, which is perhaps fairly better than them, you know. So then one would want to ask, just how then does research come in to ensure that we are serviced with all this information and that we are well placed to address the concern of treatment and care?
Actually cuts across the entire pathway, the entire patient pathway, right from diagnosis to treatment to prevention. It cuts across all those sectors. So research should be a part and parcel of care, right? So that we can even evaluate the treatment that the patients are being given. You know, we need to be able to monitor, to do evaluation, to assess, to see, are we even making an impact? Even the therapies that you're providing, what is the outcome of the therapies that they are being given? So we need to be able to evaluate that. So research will be a part and parcel of the entire pathway along, along the care pathway, from when the patient is diagnosed all the way to treatment, to know the survival, to know the outcomes. It should be part and parcel of that. But in most cases, we're not doing that because, of course, as you've heard, there's limited resources for research. So that is usually the biggest challenge. But essentially, it's supposed to be, part of the health systems. You should be even analyzing the health system to see, is our system serving our patients? There should be research on health system. There should be research on prevention, on risk factors. You know, when a patient is diagnosed with cancer, it shouldn't just be, okay, we need to treat, but we also need to ask the question, why did this patient have cancer, right? And be able then to look back and look at the risk factors to be able to address that. So the research really should be a part and parcel of the entire care of the patient that we are serving. I think we've heard also from our audience about the many challenges that come into play, the misdiagnosis, the long waiting queues. What can we do so that then we can be able to reduce the burden? Daktari has talked about public-private partnership, right? Right now, yes, we have the treatment machines, but you find that there are long waiting times. Someone has to wait for 4 months. For example, in KUTRH, they have to wait for a long period of time to access treatment. So how can we partner, maybe with the private sector, so that those long waiting queues can be reduced and we can utilize even the resources of the private sector? So these are conversations then that the government and the private sector can have, so that if patients are onboarded on SHA and they go to Aga Khan Hospital, they can still access radiotherapy as opposed to waiting for 4 months to be able to access that in a government facility. So I think those are some of the conversations we need to have. The World Cancer Day theme emphasizes on action, taking action. What kind of action are we taking as government? What kind of action are we taking as healthcare providers? Why should patients be referred several times before they're diagnosed with cancer, right? So we need to be able to evaluate ourselves. We need to be able to assess how are we serving our patients, so that if a patient is being diagnosed at a community level or at the county level, sub-county level, they should not be taken back and forth along the care system before they're actually, moved to the right place. And it also takes, us also as individuals, we also need to be able to take action to say, I have gone to this facility, I've not gotten the care, should I move to the next facility? So as individuals as well, taking action to ensure that we are taking charge when it comes to our health. So we need to be able to evaluate our health systems, we need to be able to assess, we need to be able to put funds so that then researchers are working together with the clinicians and being able then to do research that affect or rather impact on the outcome of the patients.
I am curious, maybe just to loop in Daktari, and perhaps in relation to that, that most of the Kenyans will tell you that anytime they have dreamt of traveling to India or maybe abroad, it is because of a health concern and cancer, to be precise. Let me just make a correction here and talk about the numbers in terms of the continents, that Asia stands at 49.2%, Europe stands at 22.4%, North America stands at 13.4%, Latin America and Caribbean stand at 7.8%. Let's come to Africa, where we stand at 5.9%, not 50, as I had said earlier on. So 5.9%. And then in terms of research, I want to trust that maybe this has triggered the minds of researchers to figure out why is it that we always have to find ourselves traveling abroad, in as much as we understand that maybe the situation in terms of health in the country is not at its best. But do we even have Kenyans that have the confidence and the belief that they can get the best of healthcare in the country, even as we struggle to advance?
Thank you very much. I think I'm not going to belabor the issue of misdiagnosis and quality of training. You see, I think there was a race to address the doctor-patient ratio, the doctor-population ratio. and therefore there was ballooning of universities, recruitment of so many students that, as it is, outstretched the capacity to train. So, but that is something that is being addressed. So the issues of misdiagnosis, I think those ones are isolated cases. Generally, I think Kenyan doctors, the majority are able to make a diagnosis. So I think one case should not discourage us. Two, I think at the University of Nairobi, we have a curriculum that is quite elaborate to train doctors to address the health challenges. And we have two such programs, that is the medical oncology fellowship and the radiation oncology fellowships, because we noted that there was a huge gap in terms of well-trained personnel to address the diagnosis of cancer. And the diagnosis of cancer sometimes is not straightforward, and it requires a system that is not only present but ready. The readiness of the system is very important. If you look at the the health facilities, there are almost 3,000 or so health facilities in Kenya, and you ask yourself how many of those facilities have the histology, pathology specific for cancer, which we call histological process. How many of those facilities? You'll find is less than 10%. So you have well-trained doctors. And actually, even if you look at the number that go to India, it is only that it is highlighted. When one person goes to India, thousands are likely to know that so and so went to India and was treated and got cured. But the ones that we cure here in Kenya are rarely talked about. So I think the first thing we need to do is to really do what Anne was talking about. Let us reevaluate the services that we provide and translate this to a way that the populace is able to understand. Because the general feeling is that if you have cancer and you're getting treatment in Kenya, you are getting substandard treatment, and that if you had the means, you will go to India. Yeah. Yet we know that we are able to achieve much, and Kenya actually has well-trained medical, radiation, hemato-oncologists who are able to respond to the cancer burden if the system is quite responsive and is able to address those issues. Now, Dr. Matendechero, when we sit with these patients in the clinic and they come and tell us that Shah has told me I cannot access care anymore, we feel a lot of pain. And, these are the cases that go out there, progressive disease, get very negative report about Kenyan patients. Now, India has a model that I think attracts patients. And this is a comprehensive care where you have the bits and pieces of care that is needed to manage a patient in one sort of establishment. That is something that we lack. And the case that is being shared here by our cancer survivors is a testament to that. You need to see a radiologist, you're sent somewhere. You need to see a counselor, you're sent somewhere else. You need to see a nutritionist, you're sent somewhere else. So you do a lot of walking, and if you do not have a navigator, then these patients get lost in between. And in India, what they tell you is when they enter a clinical scenario, the surgeon is close by, the medical oncologist is close by, the radiation oncologist is close by. So the decision is made within the short period of time that is required. Now, the documents are in Afya House about comprehensive cancer centers. As we speak, we only have, I think, about 2 or 3 comprehensive cancer centers, in 6 in the public space. They are all in major towns, serving 20% of the population. We have 80% who cannot access the comprehensive cancer services. Thank you.
Asante sana Daktari Omondi. Na mtazamaji, tunaendelea na kikao, na kama ndo mwanzo unajiunga nasi, tunaendelea kudadavua swala hili la saratani ili tuweze kufahamu fika mzigo huu unatoka wapi na ni vipi tutapata suluhu ya kuweza kupata tiba mwafaka kwa changamoto ambazo zinatokana na saratani. Na vile vile mwandishi wetu ambaye mwanahabari mwenza ambaye ni Sheila Chelangat anaendelea kutangamana na Wakenya ambao ni washikadau wakuu. Kuna wataalamu wa lishe, kuna watafiti na vile vile kuna wale maafisa wa afya nyanjani maarufu CHPs. Sheila, nakupa usukani, washirikishe pia.
All right. Thank you very much, Joash Onsare. And just before we engage the audience, the panelists are speaking about access to these cancer treatment centers. And oftentimes in the villages, they can access the community health promoters. So let's get to hear from a CHP. Are you trained in matters cancer care? Are you empowered enough that now you can be able to see some of these symptoms and help in the detection and diagnosis of cancer?
Thank you very much. My name is Agnes Njoki from Umoja Health Center. I'm a CHP. When we call ourselves CHP, these are the community, well-trained community health providers who give basic care to the community, educate them, and also educate them. When it comes to the matter of the community, you know these are so many people we are dealing with. And there are so many challenges we face in the community. Because these people, we get them in different ways, different beliefs and the way they see things. When I talk about challenges, let me start with the challenges we face as the community health promoters to the community. These people, they educate themselves before you educate them. And the challenges we get is before you go tell them about the good thing and the better thing of the getting tested of cancer before it gets too far, they start challenging you. I'll talk first of all about this HPV virus and the injection. This is something that we are getting a lot of challenges in the community. These people, they have come up with some ideas that this is a family planning, this is something that will stop our girls from getting pregnant. And for them to give them the correct information that this is something that will prevent the girls from getting cancer, you have to take a lot of time. One thing about the community, it comes with so many aspects. People come from different places to come and educate them. There are so many groups that form themselves in the community, telling them that this is a healthy way for their girls to get the proper and to get prevented from cancer. You'll have to take a lot of time.
Right.
I would urge the government, and especially the Dr. Sultana, I would urge the government to give us free medical camps, right, especially in our community, where doctors can come and educate these people. For us, they see a community health worker. Yes, we are well trained, but when it comes to the matter of cancer, this is somewhere they cannot gamble. They want to hear from a doctor, an oncologist, that if I get this injection, I'll prevent my daughter from getting this virus. So if the government can give us the camps, the free medical camps, severally, many times, come to the community, educate them. Us as the community health workers, we shall mobilize this community. The good thing we can do to you doctors is mobilize these people for you.
Right.
Then you can come and you educate them. If they hear from you, they'll know the goodness of this injection.
Mm-hmm.
Because in the community, before they agree on something, they have to get it from the live person.
Right.
Yes, we try our best to do it. But we need a doctor. We need camps. We need so many free medical camps.
Mm-hmm.
And make it free. because in the community, there are those vulnerable. If you tell them about HPV is free, they will say, if you go to the community and if they charge us, before you tell them that this is a free injection, it's a very difficult thing for them to believe.
Okay, allow me to cut you short there. Indeed, there seems to be a need for a lot of sensitization of the community. And when we will be back after this short commercial break, we will take a quick fire round of questions for our panelists as we discuss the larger burden of cancer in Kenya. Do not go too far. Keep it TV 47.